But I'd like to just finish by opening it up to some questions, final questions either on Mary's talk or other talks this afternoon or this morning that people may have left over. So I'll open it to the panel here.
I have a question for Mary. Many patients with severe traumatic brain injury come out of the ICU habituated to narcotics, and it has to create difficulty in their post-ICU management and their rehab. Is there any conversation between rehab and PICU about the use of narcotics as a sedative when pain isn't really the issue?
Yeah, that's a great question. I think we're probably really fortunate here because I don't see narcotics used often in our ICU, and even sometimes I'll say I will even push a little bit. Are we considering if there might be more pain here than is actually present? But I do think that's a general rule of thumb is to avoid sedating medications when at all possible. And then once they're on them, you have to be cautious about tapering them because they're in a setting where I think they're especially sensitive to a fast taper.
Can I just help address that? So we, as part of our pathway, we've really tried to use non-pharmacologic modes of sedation, reducing agitation like music therapy and some virtual therapies as well. But we've switched, when we are using pharmacology, we've switched to dexmedetomidine as our first choice, primarily because it allows for neurological examination of the child. And so, that's if we're thinking that we're going to be able to, depends how severely injured they are. I'm not saying that it's suitable for every child, but our first line is really considering Precedex or a combination of fentanyl and Versed, with really doing some assessments every day in terms of dose reduction and early weaning.
And I would just add that I think in the setting of multi-system trauma where our patients have severe TBI in addition to other organ injuries or other fractures that can induce pain, it's really important, especially in the early phase, that we do treat their pain. But we do make a conscious effort to try to minimize the narcotic use and transition then to longer acting medications and work on a withdrawal plan. And we, in addition to, we work really closely, obviously, with our pharmacists and other people who spend time thinking about titration parameters to minimize the narcotic use and to get them off narcotics as soon as we can. And Mary, I had a clarifying question for you on the use of amantadine. You said that you tend to use that in the first week. Is that the first week of rehab, or can you clarify that?
Yeah, I'm sorry, that was maybe confusing. The study that we did was just whenever you're starting it, it wasn't necessarily the first week, or it could be a month later, but during the first week of amantadine, that's the dose that we use. I think that's a fabulous question that I'm not sure that anybody has an answer to. When do we start amantadine? How early should we be starting it or considering starting it?
That's great. I wanted to ask Monica a question kind of following Mary's talk. We're very fortunate here, I think, that we get rehab involved very quickly in these patients. And I think that certainly, feels like and seems like has an impact on their long-term outcome. Is that somewhere in your guideline and what you guys have you looked at that piece at all in your work?
Sorry, you're asking about rehabilitation?
Yeah, getting them involved early by the guideline.
So, right. So that is absolutely correct. Rehab is consulted upon admission of every child with severe TBI within 24 hours. They at least do a check-in. And how they follow up, the frequency is really left up to them, but that consultation is made very early after admission.
And there are some actual clinical trials that are being investigated now to look at early rehab and outcomes. So maybe we'll have some more information on that in the future.
Great. I have a couple questions, probably probably for anybody, but maybe more directed towards the neurosurgeons that are still on the line. One that was from earlier was regarding the use of ICPs for infants with open fontanelles. Monica, you kind of alluded to the fact that in peds we're less likely to use ICP monitors in general than adult centers, but this question certainly comes up about ICPs with open fontanelles, and curious people's input or thoughts on that topic.
Well, I think there are a number of reasons fewer infants get ICP monitors than older children. Abused infants with severe TBI often have the predominant injury is often hypoxic ischemic in nature, and most of us don't believe that ICP management is beneficial for hypoxic ischemic encephalopathy. And beyond that, I think that I don't have any other comments beyond that. I think it's an interesting question, and I'm going to monitor my own behavior going forward.
That's a tough thing to do.
I agree with him. I think it's something I need to look at a little bit more as well. But one of the you can usually tell based on the fontanelle, the imaging, the head circumference, if they're under a lot of pressure or not. We tend to just treat these children like they do have pressure. One of our main treatment options, second tier, is a decompressive craniectomy. I think there's much less value in the infants who still have especially the very young ones who still have an open fontanelle, but I don't have a lot of evidence to support that. But that's something that I'll certainly be taking a look at as well in my own practice.
It's very interesting because when we talk to people around the country, there's so many perspectives. There are some people who believe that inflicted injury is somehow intrinsically different from non-inflicted injury, and I think what our previous speaker was saying, that it's predominantly hypoxic injury. I think one could argue that to some degree, there's a final common pathway, and when the brain's dying, it's dying, and the final common pathway is hypoxia. So the question really is, and these kids with inflicted injury have often had inflicted injuries before. They're presenting late to our trauma centers. We don't know how salvageable the brain is. And so, I think we bring our own impressions. I don't have the answer, but the guidelines don't say if you have inflicted injury or you're abused, you are not a candidate for ICP monitoring. We're not ready to say that yet, but at the same time, we're not willing as a community to say, these kids may also benefit. Now, partly is because it's technically difficult. We think there's a pop-off. The truth is there's very little data to support what we ought and what we ought not to do.
That's great, Monica. Thanks for bringing that up. That's certainly a common theme.
One other comment I have, sorry to interrupt.
Go ahead.
The other thing to keep in mind is that the skull on these children is much thinner than the average patient that we're putting these in. So I worry quite a bit that with movements or activities by the physicians or nurses might actually dislodge and cause additional injury with the standard cranial pressure monitor. And sometimes the optional different treatments, different ICP monitors are hard to come by or a little more technically challenging.
All right, I'm going to try to throw out without keeping us here till midnight, so I'm going to encourage everybody to kind of brief answer to this question that came across online. But the question really said, unfortunately, we've had 3 anoxic brain injury deaths this past summer, including a recent case of a 3-year-old who was pinned between the tailgate of a truck and a garage door for an undetermined period of time. Our understanding is that mannitol or hypertonic saline is not indicated in this scenario, but our PICU physicians still want to use these modalities when focal neurodeficits develop as the brain diffusely swells. What is the opinion of the experts here? That's the question from the crowd, and I know that's a big question to answer in a brief time, but I think it'd be useful for everyone to kind of hear some opinions on that.
I think the guidelines don't specify for whom these therapies are warranted and for whom they're not. So they don't say, if you have a subdural, it's warranted. If you have a frontal contusion and you have, subarachnoid blood, it's not warranted. I don't think TBI is a very heterogeneous condition. And I think we're looking at the phenotype, which is what is severe TBI. But what you're asking is, what are some mechanism-specific treatments that are recommended? And I think the reason the PICU docs are using hyperosmolar therapy, even in those circumstances, is because we don't know what else to do. And you know, we know that hyperosmolar therapy reduces ICP, and most of the countries using hypertonic saline over mannitol right now. That's what the data would suggest. But I think if, you know, I think Rich, maybe you said earlier, we're trying to do what we can do to help these kids. We're not ready to give up on them. And I think that's what's driving the practice.
Yeah, I would just add that I think especially in the acute setting where it's not clear, the downtime the arrest time may be unknown, that we would typically use hyperosmolar therapy in that setting and then make a decision on whether an intracranial pressure monitor would be inserted or not. And then at that point, maybe back off our treatment if we're not going to have a target to treat to.